All right, so welcome everyone. I am recording this so that we can send it to all of you after, and we can send it to anyone who wasn't able to make this call tonight live. So I will be emailing this recording to everybody after. As I said, my name is Casey Greer, and we're really, really happy tonight to have Dr. Tom Porter with us and Dr. Hallie Nyans. Sasha Stroll, are you here, Sasha? Calling out, because I know some people are here without their names. Sasha should be on her way as well to chat with us tonight. But basically, the way this is going to go is we have some questions um, pre-prepared already, and Dr. Porter is going to ask those. But we would love to hear from you also. So if you have any questions while we're talking, please feel free to put them in the chat. I'll keep an eye on the chat. Also, you can ask a question verbally if you would like. Um, and yeah, so we would, Dr. Porter, I've messaged Sasha, so she'll probably be here shortly, but if you wouldn't mind getting started, and yeah, we'll take questions also from any of you in the chat. So,
Great.
all right.
Ready to go?
Ready.
Okay. Um, I thought I'd give you just a little bit of background about how this all came about. Uh, Quite a few years ago at one of the NOAA conferences, I I gave a program called What You Do When You've Been Told Nothing More Can Be Done. And there were so many questions from parents and grandparents of kids with albinism, and I really felt like that it would be better addressed by either a pediatric ophthalmologist or a pediatric optometrist. So that's really kind of the background. So hopefully we've got parents and grandparents and things that uh, have burning questions. Dr. Nyans is an associate of mine. Um, you want to give your, I shouldn't introduce you. You can go ahead and say a little bit about yourself before
Yes.
we get going on this.
Sure. So my name is Hallie Nyans. I am a pediatric optometrist. I work alongside Dr. Porter here in St. Louis at St. Louis University Hospitals and Cardinal Glennon Children's Hospital. I work alongside some of our ophthalmologists, and then I also see patients by myself.
Right. We have a big pediatric practice. We've got four pediatric ophthalmologists and two pediatric optometrists. And there's a role for everybody in this. Now, I see many people with albinism, but not little kiddos. They start showing up in my practice when they're trying to find out if they can drive or work related, sometimes schools. But Hallie, one of the things that always fascinates me, I'll see a little kiddo in the clinic who's clearly got albinism and they've got glasses on, yet they can hardly talk. How in the world do you ever come up with an eyeglass prescription on a nonverbal little ped?
All the needs. Yeah, this is a great question. And this is a question that I answered even today in clinic. A lot of times families are wondering, for someone who can't do which is better, one or two, how do we figure out the glasses prescription? And the way that we do it is in our practice, in most pediatric ophthalmologists' practice, we dilate the eyes. And this serves two purposes. So, first, it makes the pupil really large so that we have a lot of reflective area to see our flashlights and everything and to look at the inside of the eye. But dilation in our practice also serves a refraction or a glasses finding purpose. So, kids especially have very strong focusing muscles inside the eye. That's the system that starts to go out around age 40 when you or your parents, or people in your life start to do the like, oh, I can't read this anymore, I have to push it away. That focusing system is very strong in kids. And sometimes when you have a kid who needs glasses but doesn't have them yet, those focusing muscles can over focus and tense up even when they should be relaxed to overcome the blur that they might be experiencing. So if I measure a kid for glasses with my flashlights before dilation, I don't really have any way of knowing if those focusing muscles are over focused or if they're relaxed like they should be. So my dilation drops temporarily relax those muscles so that I know I'm getting the full picture of any refractive error or need for glasses that's there. And then I have a special flashlight with a little topper that I look through called a retinoscope. And I hold up different power of plus or minus lenses in front of the eye. And I look at the way that the light looks in the person's pupil. And that's what tells me I need to add more plus or I need to add more minus, or there's astigmatism. I have to figure out 2 different prescriptions per eye. And then we bracket down until the light looks neutral, is the term. And that's the kid's prescription. And then we use that information compared to the age of the child and what we expect refractive error to be at their age to determine if they need glasses.
Oh. We don't do that with adults very often. Um, so again, my experience is more teens and beyond. Do you see more prevalence of nearsightedness, farsightedness? Most of mine have high astigmatism, but again, do you see more of one than the other?
Not necessarily. I see high refractive error or, high powered glasses, but it can be plus or minus or high astigmatism. It can be any of the above.
Is I wish that Dr. Struhl was on right now, but again, you can tell me a little bit about what the pediatric ophthalmologists feel. Do they try and put a youngster in, assuming they've got a big refractive error, a big need for glasses? Do they put it in just right away when they're really little kids?
Yeah, that's a great question. So there's a natural process that children undergo, usually around the first 5 years of life, called emmetropization. And the idea is that the body wants to have zero need for glasses. I want to be able to just see clearly far away and up close. So babies are born with a really wide range of glasses prescriptions. But for the most part, everybody kind of moves towards zero in those first 5 years of life. And so if I see an infant who's under 1, I could even see a pretty high prescription and say, this is still normal for a 1 year old, and there's a good chance that they'll outgrow it. Now, if that prescription stays high, even as they grow through their toddler and preschool years, then we're more likely to give glasses because it becomes outside of the normal range. But we have to look at the age of the patient as well as the magnitude of refractive error and how well the patient is functioning. So some people have a very high tolerance for blur and they can still see very well, even with an uncorrected need for glasses. Other people, like we joke that engineers are like eye doctors' worst nightmares because they're very particular about getting exactly the right prescription. So they have a very low tolerance for blur. And kids are the same way. So some kids really want their glasses prescription, even if I might say it's kind of minor.
Okay. Um, I know that your practice is dependent on the pediatrician referring the kids to you. You don't go stand out on the street and try and pull them in. But if you were in charge of things, how early would you start examining all pediatric patients? And then specifically, second question would be in those with albinism.
I think patients with albinism should get an eye exam before age 1, and they should be seen at least annually, if not more frequently than that. Patients with albinism have a higher risk of developing other eye conditions like an eye that crosses in or drifts out, which then is a risk factor for developing other eye conditions. And so we want to keep a really close eye on patients with albinism and making sure that they're in the best possible glasses for them, that they are wearing sunglasses and hats outdoors, that we're always checking for any signs of, cancerous kinds of things because patients with albinism are at a higher risk for that. So certainly as early as possible and at least annually. Even patients who are normal, who don't have any eye concerns, I always like to check them. I think every year, which is the American Academy of Optometry recommendation, and American Optometric Association usually say an exam before age 1, and then usually every year or 2 years after that. We see patients even who came in for something completely normal, they have a little bump on their eye, but parents don't have any concerns. And it turns out that the kid is like has a really high prescription and really needs something urgently. So sometimes we find things even that families aren't expecting.
A lot of the teenagers and adults that I see with albinism have nystagmus, the wiggling of the eyes side to side, and there's quite a range that I see from almost what I call a micronystagmus to really, really big excursions. Do you see that in your practice? Is it
Absolutely.
most with albinism or just
In my personal experience, and Dr. Stroll may have a different experience, but in my experience, yes, a lot of the patients with albinism, that is usually, maybe not usually, that's often what brings them to the eye doctor, especially if they don't have the characteristic very fair complexion and very fair hair. If there's just ocular albinism that only affecting the eyes, very often that nystagmus or shakiness is the first sign that parents see that something is wrong and they need to be seen.
I don't know if there's been any research on this, but um, do they perceive the world as shaking?
I believe that there were people on this call last year with nystagmus and they reported no. They said it looks a little blurry, but it doesn't look
Okay.
Correct. Can confirm.
Okay.
like I can't speak for
It's
your
not
family.
it's not shaking.
Okay. Um, so there's an eye condition called strabismus, and I'm sure that Dr. Nine sees a lot. Do you think that there's a higher percentage of those with albinism that develop a crossed eye either in or out?
Yes, so albinism does increase the risk of strabismus. Strabismus is any eye that deviates in any direction. So you could have an eye that crosses inward toward the nose, that goes outward, that drifts upward, or goes down, and that would all be considered strabismus. The difficulty with strabismus is the brain does not like to see double. And so if I have one eye that's pointing straight ahead and one eye that's drifting out, the brain goes, I'm not trying to look over there. I'm trying to look straight ahead. So I'm going to ignore the image that comes from this eye. And if that ignoring goes on for long enough and for consistently enough in early childhood, then the brain and the eye connection doesn't develop the way it's supposed to. And then you end up with something called amblyopia, which is blurry vision in a healthy eye that's not correctable with glasses. Essentially, the brain didn't learn how to see out of that eye because it ignored it for too long and too consistently. And so, again, that's another reason why we want to see these patients very, very often for comprehensive eye exams, is to make sure that we are getting equal vision development and we don't have a preferred eye and an eye that isn't seeing very well.
When I am examining a teenager and with the hope of being able to drive, one of the things that I notice is when I really push them on the eye chart, they'll turn their head and assume a certain posture, and um, that null point that certainly does improve their visual acuity a bit, which I assume is because it slows down the nystagmus. But is there anything that we can do to fix the head turn?
So again, I would have to defer to my ophthalmology colleagues about this because now we're getting into the realm of surgery. So some pediatric ophthalmologists will do eye muscle surgery to help essentially put the eyes where the nystagmus is the least, and so where the vision is the clearest. So patients put their head wherever their eyes don't want to go. So if my nystagmus is the biggest when I look over to the left, and it's the best when I look into the right, then I'm going to turn my head to the left so that my eyes are looking this way to the right, and then I have the best possible vision. So some ophthalmologists will do surgery, especially if the head turn or tilt is affecting other systems in the body. So if we're getting neck problems, if we're getting asymmetric facial development because we have a constant or significant head turn or tilt, sometimes they will do surgery for that. And those surgeries are outside of the eyeball. So the eye muscles that control whether my eyes go up or down or left or right are on the outside of the eyeball. And so it is a relatively lower risk surgery in terms of eye surgeries because it's outside the ball, outside the globe.
Dr. Porter, I'm loving your questions, so we can continue those, but I do want to let you know we have three in the chat if we want to get to
I,
those.
I'd be happy to take a break from my questions and
Sure.
answer some. I've I've got plenty more, but
Yeah.
I don't want to dominate this.
No, I mean, we can go ahead and do some of these and then go back and
Let's
forth a
do.
little.
Let's do a few of these and then we'll jump back.
All right. The first one is why does blowing a balloon or an instrument slow nystagmus?
So nystagmus sometimes can be improved with convergence, and convergence is crossing your eyes. So for some patients, the nystagmus is worse when they look far away, and if they hold something very close, the nystagmus lessens considerably. So I imagine that that's what the question is getting at, that when you blow a balloon or if you blow an instrument, your eyes are focusing much closer.
That's cool. I didn't even know that. All right, another one is what are the different types of nystagmus and what extent is the type related to visual acuity? And then also same person says, how does nystagmus change as children age?
So there are a couple of different kinds of nystagmus. There's what's considered jerk nystagmus, which has a slow movement and then a fast movement. So slow and then it jerks back. And this is what you see sometimes in normally sighted patients when they look all the way to one side or to the other. Sometimes you can get a little bit of a jerk nystagmus all the way over if you're kind of stretching your eyes. And then there's also something called pendular nystagmus, which is basically a slow phase in each direction. So it just kind of drifts back and forth, but the speed is the same in each direction. Um, I don't, I don't know the answer to if visual acuity is better with one type or the other. It probably depends more on the magnitude. So how big the nystagmus is. Dr. Porter certainly be open to hearing your experience with that as well. And around nystagmus changing. I have seen primarily toddlers with albinism, and I just haven't been in practice long enough to see them grow up.
I've seen them grow up, have families, become grandparents.
Yeah.
Uh, seriously, in my experience, pendular nystagmus tends to be a little bit better acuity than jerk nystagmus. There's another type that I've never seen in a child. I've only seen it two times, and that's rotary nystagmus. It's the first time you see it as a doctor, believe me, you'll never forget it. And then nystagmus can be caused actually by toxicity to certain drugs and head trauma, but that's kind of not where we're going with this. You know, another thing that I've noticed too, Hallie, and it's unfortunate. I need to get the best visual acuity you can possibly get if we're talking about driver's license. But of course, the harder they concentrate on anything, the the more the nystagmus becomes an issue. So it's just a catch-22 sometimes. Are there some other questions, Casey?
Yes, yeah. So on that same one, how does nystagmus change as children age? Does it change or do you see a change in that?
I know some of my patients with nystagmus, although I can't tell you if they have been confirmed with albinism or not, because we are still waiting on genetic testing results. We had a pair of twins come in as infants, both with nystagmus. One twin has outgrown the nystagmus and one has not, and we are currently undergoing genetic testing for those patients to see. Um, I think nystagmus, when it's by itself, sometimes can be outgrown in infancy, but I'm not sure. Like I said, Dr. Porter, I've seen mostly young kids and I haven't been able to follow them for a
Yeah,
decade yet.
yeah.
Yeah.
Uh,
We have two more questions. Have you ever, I hope I get this right because I don't know this word. Have you ever recommended occlusion on the glasses to train the eyes?
Yeah, so I think they're asking about occlusion or covering one eye, and yes,
Uh-huh.
absolutely. So, um, nystagmus is tricky. Sometimes nystagmus can get worse if I cover one eye. So we have to be careful with nystagmus. Sometimes in an eye exam, I have to, be very watchful to see, I need to check the vision individually, but I can't cover one eye because then the nystagmus gets so much worse and it's really not a good representation of how well the patient is seeing. That's called a latent nystagmus. So it kind of presents more with one eye occluded. But as I was talking about strabismus and amblyopia, that blurry vision caused by improper development of the eye and brain connection, one of our primary treatments for amblyopia is occluding or covering the preferred eye. This is typically done with an adhesive patch that's like a Band-Aid that you stick on under the patient's glasses. You cover up the preferred eye to force the brain to use the eye that it doesn't like to use. So the eye that tends to deviate, or an eye that has a very high refractive error compared to the preferred eye. And this allows the eye and brain connection to develop the way it's supposed to. It's usually a limited treatment, so it's most effective in children under age 8 to 10. Although if you've never patched before and you have poor vision in one eye, sometimes we'll try it with older kids as well.
Is there an age where you normally will let me see it. Let me try it in my terms. I would assume the sooner you make a decision to patch, I'm talking about age-wise, the more likely you're going to have a better outcome. Does that sound right?
It depends. So toddlers, as you can imagine, don't like when you take away their preferred eye, and babies and toddlers can have a very difficult time complying with the therapy. So sometimes we get better results even with, a 4 or 5 or 6-year-old patient, just because they're actually able to complete the therapy. I think, of course, the earlier we can get patching in, the better, because then you develop proper vision earlier, and then that gives you a better chance of having normal depth perception, normal eye teaming or eye alignment. So it becomes a virtuous cycle when we can patch and get equal vision earlier in life. But that can be hard. Patching is very difficult on young children.
We have someone raising their hand, and I can't call your name because it looks like just a phone number, and you're muted also. But if you meant to raise your hand for a question, if you want to unmute and ask it, that's fine. Here we go. Are you there?
Hi, thank you so much. Yes, yeah, thank you so much for being here. I really appreciate all of the information and you making the time for this conversation. And I'm sorry I couldn't join via computer, but happy to be here.
No problem.
My question, well, a couple questions. Thank you for talking about patching. I know that's definitely a question and challenge. One question with that is if anybody's had, or if you have any suggestions, because my little, even with like the quote gentle removal ones, it still like pulls her skin off a little bit, and she doesn't like it. And I think they didn't like the cloth ones, but like she'll wear that one because. So I was wondering if anybody had recommendations, or if you had a recommendation for. Like for a patching solution that will have coverage, but maybe not
be as rough,
pull the skin. Yeah. And then also if you had any thoughts on, and I don't remember the right word for it, but like the elongation of the eye, if there's anything to help support that as well.
Yes,
thank
absolutely. You. So I will tell you that the brand of patches that I use in the clinic, this is not a sponsor. I have it pulled up here on my phone. It's made by NextCare, and they are, I'm going to try and hold this up like that. They look like this. It says Opticlude NextCare. And these are, I find very gentle to remove from patient's skin. I'm putting them on and taking them off of kids' skin all day, every day. And I always tell kids it's like a Band-Aid, but it doesn't even hurt like a Band-Aid would. And I always very often show them on their hand and say, look, I can put it on, I can peel it right off. It's very comfortable. The other thing that does help is moistening the patch before you remove it. That helps soften the adhesive. So if you get it wet with a wet washcloth, that can sometimes make it a little bit more comfortable to remove. We don't like the cloth or pirate patches or patches that go over one side of the glasses because it's just so easy to peek over the patch. Kids will even especially glasses that have nose pads that kind of stick out from the bridge of the nose. They'll look this way and they can peek under their glasses between their nose. And so the adhesive Band-Aid kind of patch is really the most effective, because any amount of time that they get to use their preferred eye, they're just continuing to ignore that amblyopic eye. So that's the first part about patching. And then the other question that you had about the elongation of the eye. So an eye that is too long relative to the curvature of the front of the eye, called the cornea, is nearsighted or myopic. Now, a lot of us are nearsighted. It's when you see well up close, but you have trouble seeing far away. Most of us wear glasses. Most of us, it's not a big deal. However, for people who are very nearsighted, so prescriptions like -6 and higher, you are at an increased risk of some eye conditions like retinal detachments and glaucoma, and even some changes to the blood supply in the back of the eye. And so we really don't want people to become very highly myopic or nearsighted, because that just opens them up to further complications with the eye. So one of the interesting areas of research in optometry right now is called myopia management or myopia control. And the idea is, as children grow taller, their eyeball also grows longer. So if I see a kid who is nearsighted, and then the next year they're even more nearsighted, and then the next year they're even more nearsighted, and they're increasing at a rate that is faster than I would expect. We expect a normal amount of myopic progression from year to year, which is usually about 0.5 to 0.75 diopters more. So, I started out at a -1. The next year I come back, I'm a -1.5. That's normal. That doesn't concern me. But I start out at a -1. The next year I come back and I'm a -2.5. Well, that's a really steep change in just a year. And that gets me a little concerned that you're increasing. And if we stay on that trajectory, you might end up in that high myopia area. So then the question is, can we slow down the rate of myopic progression? So instead of ending up at a -8, maybe you end up at a -3 or 4. And that's the idea behind these methods to prevent the eyeball from getting longer. There are a couple of contact lenses. So there are hard contact lenses and soft contact lenses. There's a very diluted dilating drop. And then brand new in October, just approved by the FDA, there's a pair of glasses. And all 4 of those methods, it seems like, are effective at slowing down the progression of myopia. So again, it's not going to fix the nearsightedness that is already there. And it probably is not going to prevent more nearsightedness, but we're going to change, instead of a slope like this, we're hoping for a smaller increase time over time. So then, and we're really paying attention to that kind of up until age 16 to 20-ish is where the prescriptions usually tend to level off, because that's when our bodies tend to stop growing. Does that answer? That was a very long-winded explanation, but I hope that answers the question. And patients with albinism are at risk for high refractive error, whether that's plus or minus or astigmatism, as we already kind of talked about.
I have 2 more questions in the chat, actually.
Yeah.
So
Go ahead.
yeah, thank you all for actually 3 more now. Oh no, 4 more now.
Okay.
No, not oh no. This is a good thing. This is a good thing. So we have, is vision therapy something that can help/resolve some of these issues?
Vision therapy certainly can help. There's a wide spectrum of activities that are all kind of grouped under the umbrella of vision therapy. Some of those activities and exercises are very well established in the medical community, like convergence activities, accommodation activities, even some eye movement activities, things like anti-suppression charts where we're trying to help the eye that the brain tends to try to ignore. So stuff like that is very well established, and I think certainly can be helpful or beneficial. The downside is it's typically not covered by insurance, and it can be quite expensive. Oftentimes, vision therapy is like a weekly visit in an office with a vision therapist, and then at home practice activities, just like you would do for physical therapy. You have these exercises you work on at home, and then you check in with the optometrist, every couple of months to kind of check in on your progress. So certainly can. There is also are also exercises and activities labeled vision therapy, which are not very well established in the medical literature as being evidence-based. So I would say just proceed with caution. Most of those are certainly not going to harm the eyes, but it may be expensive with little benefit. So proceed with caution on some of that.
Awesome. The next one is, what advice do you have to help with issues that glasses won't help?
So it probably depends a little bit on what the issue is. So things like glare sensitivity or light sensitivity, sometimes we can do tinted contact lenses or transition or tinted glasses. That can sometimes help. Dr. Porter can certainly speak to low vision aids more than I could. So those are things beyond glasses that can help with kind of navigating activities of daily life. I don't know, Dr. Porter, if you want to jump in on some of those.
Sure. When when we when we all work together, um, if there's an issue where progress in school is being affected, where you can't do just the basic activities for daily living, things like that, then a low vision evaluation is really appropriate. Um, and as I said, I normally see kids when they're teenagers, and the reason for this is the number one way that a child magnifies things is by holding them very, very, very close. And children have just an incredible amount of what's called accommodation, the ability to do that. And they can sustain this close working distance for an incredible amount of time. But there's a couple things that go on that really affect this. When from age 1 to about 3, they're learning to read. And from 3 on, they're reading to learn. What happens to the font of the print that's in either online in the digital books or in printed books? The font gets smaller and smaller. And the amount of time that they have to spend reading and such as that goes up. So you've got accommodation that at best is level at that age, maybe even slightly declining. And you've got the print size getting smaller and smaller, yet the amount of time, and when those cross, all sorts of problems start. So we try and get involved in helping teachers with an IEP when they really start school. Sometimes first grade, once they're in school full time. Are there accommodations that you talk with parents about for school age kids?
Most of my patients have been either they're not in school yet, or they have already been set up with sufficient accommodations, and I haven't had to add
Yeah,
anything. They've been doing well enough in school.
yeah, yeah. I, I think we I think we got off track. Casey, remind us what we were supposed to be talking about.
Oh, no worries. This one was just advice to help with the issues that glasses won't fix.
Well, this is a terrible, terrible analogy, but I always think about old photo cameras. If the roll of film wasn't perfect, there was no amount of focusing that would give you a perfect photograph. And in albinism, because of the structure of the back of the eye, it essentially is the bad roll of film I'm talking about, and our eyeglasses simply focus light onto that. So uh, if we can't achieve the things we need to do, then you get into my territory, you get into the low vision aspect.
Hmm. I like that analogy a lot. All right, we have some comments. These are not necessarily questions, but the chat is just it's very active chat, which we love to see. Just saying, thank you. And a few people are saying their kids had late diagnoses because they had brown hair. Two people said that. And Jill says, my toddler who has been to two ophthalmologists, they both agree that glasses won't help ocular albinism. I definitely see an issue with albinism, but I'm also concerned about peripheral vision.
Yeah, peripheral vision is very difficult to test in toddlers. The way that we do kind of a clinical early quick check of peripheral vision requires you to look at the examiner's eye and to stay fixated on the examiner's eye, and then to be able to identify how many fingers the examiner is holding up. And obviously a toddler's not going to be able to do that. They're going to peek, they're going to look. I can usually start doing that test around age 5 to 7 for someone who's, developmentally normal. Maybe a little bit later for kids who are have any kind of developmental delays or other diagnosis that might make it difficult for them to do that test. And then the gold standard is what we call the Humphrey visual field. And Dr. Porter probably does lots of these all day long. And that is where you put your head in this big white bowl and you have to look at a dot. And every time a dot flashes in your side vision, you push a little button. And then I don't know, you do that for what feels like forever. And then it gives us this beautiful map of the peripheral vision and any vision loss that might be there. So there are certain eye diseases that can cause peripheral vision difficulties, and we are trained to recognize those patterns from a visual field. But that test really can only be done on maybe age 12 and up or so. Usually early teenagers would be kind of the earliest to do that.
Now, Hallie, my general experience is that folks with albinism don't tend to have peripheral vision problems. It'll be central vision, it'll be the sharpness, the clarity, but not peripheral vision.
Yeah, it's difficult for us to tell you for sure if your toddler has issues or if they have normal peripheral vision until they get a little older.
Right.
Anyone else? Is there anyone that doesn't want to use the chat who'd rather ask a question verbally? That's fine too.
Casey knows this, and any of you who have tuned in before may know this, but I guess of all the low vision problems that I deal with, I tend to love the albinism community more than anyone else. And one of the questions I've been asked by parents is, will my child have a normal life? And my answer is, if you do your part and we do our part, and the teachers do their part, there's very little they won't be able to do. And I used to say they'll probably never be a race car driver or a jet pilot, but in terms of being able to carry on a normal, productive life, there's very, very, very few cases where I have seen somebody with albinism that wasn't able to do that. And there's such a huge spectrum. I don't know that I'm telling anything out of school, Dr. Nyans, but one of our colleagues that you and I worked with a couple of years ago has albinism, and her visual acuity is probably 20/25. But I've seen the other end of the spectrum too. But still, just go under the assumption that with you doing your part as parents and grandparents and having good pediatric eye care professionals and good teachers that are aware of special needs, things will be fine.
Yeah.
I have two more questions in here. All right. First, if a child with albinism has had strabismus that was corrected by surgery, is it possible that it will come back?
Yes, it is possible. And that's not specific to patients with albinism. That's just true of any patient with strabismus. We don't know why some patients do very well after one surgery. And don't quote me on this. This is me reaching back to some of my training. I think around 30% of patients with strabismus who need surgery will end up needing a second surgery. We don't like to continue to operate over and over and over on patients. So we really try and we do our best to get it the very first time. But sometimes it does get worse. And sometimes it can happen, in childhood. You might do surgery for your child at age 2 or 4, and maybe it comes back at age 8 and gets to the point where we need to do surgery again. Sometimes patients do very well, and it's not until adulthood that they kind of have difficulty with that. Very often, even after surgery in an eye exam, we can still see the remnants of strabismus. I can still see that tendency for the eye to cross in or to drift out. But what we're really looking at is how the patient is functioning and cosmesis. So the cosmetic appearance, humans are very attuned to eye alignment. And so if patients, even if I can say clinically, your eye crossing or your eye drifting doesn't require surgery, some patients, especially in middle school and high school, can become quite self-conscious, or they can receive unwelcome comments from their peers. And if it becomes to the point where it's affecting their self-esteem, if it's affecting their relationships, then we might talk about doing surgery, even if it's a relatively small amount of crossing or drifting.
Hey, in your clinic, how frequently do you do genetic testing?
That's a good question. And I think we have tended to not do genetic testing if it's very apparent. If the patient has all the clinical signs to me that it's albinism, then we tend to just say it's albinism. Go ahead, and we're just going to call it that. If there's a question, then we tend to do genetic testing. So like we talked about with the twins who came in, they are not particularly fair. I don't remember what color their eyes are, but they don't present with the very obvious, fair complexion, very fair hair, very blue or pink looking eyes. And so there's kind of a question of, is this just nystagmus or is this albinism? And since the one twin has not been outgrowing it, we did decide to go ahead and do it. We have also had patients who really seemed like it was albinism and the genetic test came back negative. And so that kind of muddies the waters too, because clinically, they meet all of the signs and symptoms, but the genetic test, for whatever reason, maybe it was a false negative. We don't know, but that can present challenges as well.
We have a few more questions.
I
When
have
should my
another one.
child? Oh, go ahead.
Oh, sorry. I was wondering, could you talk me through what your flow chart would be for like age and timing and indication for doing like a surgery, or like when you would recommend that?
Yeah.
And what that flow chart would look like, please.
Yeah, absolutely. And again, this would be up to each ophthalmologist and what their criteria kind of are. So a couple of things that we look at. First is their amblyopia. So if I have one eye that's 20/20, let's say just for round numbers, one eye that sees very well and one eye that, tends to drift out, and this eye has very poor vision, let's say 2100. Well, if I do surgery, and I am not doing surgery, but let's pretend that I'm an ophthalmologist. If we do surgery and we realign the eyes, the brain really has no reason to keep the eyes aligned because this eye sees so poorly, it's just going to drift right back out. So we always treat the amblyopia first, and we have to get the vision to be equal or nearly equal. Otherwise, there's a very high chance that the eye will just go back to where it wants to be, because the brain isn't motivated to keep the eyes aligned, because that's not a very useful eye comparatively. So number one is their amblyopia. We need to treat that first. The next thing we look at is frequency. So for example, for someone whose eye drifts out some of the time, but not all the time, we are looking very often at the 50% mark. Is this something, I ask the parents, if you think about a typical day that you're with your kid and you are looking at them frequently throughout the day, how much of the time do you see that one eye's drifted out versus their eyes are aligned? And if the parents say 75% of the time he's got an eye drifted out, I say that's a lot. We're above the 50%. We should talk about doing surgery. If they say, oh, it's like 5% of the time, I see it a couple times a week, I say he's got great control. We don't need to do surgery. Even if you see eye drifting, he can get it back. We don't need to do surgery for that. So frequency, and then magnitude is the other big one. So we have little blocks of plastic or glass in our offices called prisms, and that helps us quantify the angle. So if, instead of my eyes being straight, I have an eye that's crossed in. Is it crossed in a little bit? Is it crossed in a medium amount? Is it crossed in a lot where it's almost sideways? It's pointing directly at the nose. So the prisms help me quantify the magnitude or the angle of misalignment. So then each ophthalmologist is going to have kind of a different number for where their threshold is to do surgery. Smaller magnitudes, things like under a 10 to 12 are not usually cosmetically noticeable, meaning I could be walking around with a 12 prism diopter exotropia or esotropia, and you would look at me and think my eyes look aligned, even though in an exam I might be able to measure eye crossing or drifting. If it's above that, kind of 12 to 15 is where people start to be able to notice it. And sometimes people can, that's when we kind of talk about doing surgery. Does that answer your question?
Yes, thank you. In terms of the kind of, for your kind of ballpark 50%, is that with glasses on
With
or
glasses.
without glasses?
Always with glasses. There are some kinds of strabismus that glasses can either partially help or can sometimes even fully help. And so parents will say, you know, well, their eyes look great when the glasses are on. And then as soon as we take them off, their eyes go super crossed. And I'm like, I don't care what happens when the glasses are off. I only care about when their eyes are seeing through the glasses, through the best possible vision. What does their eye alignment look like?
Thank you. That's super helpful.
Yeah.
We have about 10, 15 minutes left. I want to be respectful of everyone's time here. I'm sure Dr. Porter or Dr. Nines would be willing to even contact via email. I mean, I'm putting you on the spot, but hopefully that would be okay if anyone has any extra questions. But we have two more in the chat I want to get to. So one is, when should my child start low vision driving? He's almost 15. According to a NOAACON speaker, I was told he should be able to drive. I think that NOAACON speaker is probably here. I think it's probably Chuck. Chuck is here. But yeah, anyone want to touch on that?
I think that probably has more to do with how well they see rather than the age. So there are patients with albinism, like Dr. Porter was saying, who have normal or nearly normal vision. And there are other patients with albinism whose vision is very low. And I wouldn't expect those patients necessarily to ever be able to drive. But I would certainly defer to Dr. Porter since this is his specialty.
Well, I'll put a little advertisement in. There's a fantastic one-day seminar at the upcoming NOAACON on the 16th, and we're going to go over everything from the low vision exam to what tools we have, and equally important is driver readiness training, and on and on and on. And I really would encourage anyone that has a youngster that's approaching that age to take advantage of this. I mean, even if you can't come to the conference, I believe that it's available where you can attend online. Okay, getting back to as specific as I can get, I start seeing youngsters anywhere from 14 to 16 to find out if they visually qualify or can qualify. And those are the things that I can do. Should they qualify with a special pair of glasses, let's say. That's the easy part are my parts. The hard things are then training the youngster in using that specific device behind the wheel. And that in and of itself is, there's a lot of science, but there's a lot of art to it also. And I don't know whether Chuck feels like saying anything tonight, but Chuck Huss is probably one of the, if not the world's leading authorities, definitely one of the U.S. leading authorities on driver readiness training. Chuck, are you there?
Just a couple of short.
There he is.
Thank you. A couple of short comments. As you've mentioned already, being pre-driver ready is extremely important. And that's usually done under the auspices of a certified orientation and mobility specialist. But something that I will advise parents, if your son or daughter is of driving age and they meet the visual requirements indicated by the state for driving, especially for selective or restrictive driving, and let's say that formalized training in your particular state is not a requirement. One thing I caution you about, do not teach to test. In other words, don't take them out if you absolutely know the route that they're going to be tested on so that they can pass the test to qualify for driver licensure. You will regret that. So seek out the services of a certified driver rehabilitation specialist for not only evaluation purposes, they will advise you whether or not your son or daughter is pre-driver ready, and then go from there. More and more states are going to third-party funding for formalized low vision driver education training. And it's now accepted in 48 of the 50 states here in the United States. And it's spreading across Canada as well. I'm aware of at least 5 provinces in the country of Canada that now allow bioptic driving. So I hope that answers your question.
Yeah, thank you, Chuck. It's always great to have Chuck here. I feel like driving comes up a lot, so it's always great to have you here, Chuck. I think we have time for one more, and I do have one in the chat here. At what age can you tell what someone's best corrected visual acuity will be?
Yeah, the age of visual maturation is usually around age 8 to 10. So assuming that the patient has had kind of optimal care with a pediatric ophthalmologist or optometrist who knows how to manage albinism, they've been, treating any amblyopia, they've been getting them into the proper glasses with a cycloplegic or dilated refraction. Usually around age 10 is when we can kind of say, this is probably what your vision will be. However, if you have an older kid who has not had eye exams, they haven't been in glasses, they haven't done any patching, but they maybe needed to, we've seen improvement even after age 10. The improvement that we see after age 10 usually is the greatest when patients haven't had any therapy or intervention before. So I see a brand new patient, they've missed out on the eye health care that they needed. We get them glasses, we start patching. Sometimes we see even dramatic improvements in vision, but usually around age 10.
Great. I guess we have time for one more. Anyone? If not, that's fine, but
I have a comment, and it really, really hit home today in listening to Hallie. These kids need a team to really do well. They need not a general ophthalmologist, they need a pediatric ophthalmologist. Hopefully, the pediatric ophthalmologist has someone like Hallie, a pediatric optometrist, not a regular optometrist, a pediatric optometrist. Like it or not, most of these kids do not grow up with normal vision. Therefore, there may be some help that a low vision specialist could offer. So again, it may not be in your hometown, but it's probably worth that 1 hour, 2 hour, even 3 hour drive to seek out the people that I'm describing to you. Because, I always tell my now adult children, life isn't a dress rehearsal. We've got one shot at getting this right. And it's well worth the effort to do everything we can for our kids.
Yeah. And I can speak, at least in Missouri, we have programs for like children up to age 3 called First Steps, which is like early childhood intervention, as well as we have Delta Gamma, which is an organization here that serves blind and low vision children. Is it up to age 3, Dr. Porter?
Up to
Age
3.
5?
My youngest daughter just went to work for Delta Gamma, so I'm very familiar with it.
Oh, that's wonderful. So there are also, depending on what state you live, there are probably early childhood interventions through the state, as well as low vision interventions for children that can get you resources that can help support the cost of glasses or low vision aids. So there are other resources as well.
wonderful. Awesome. Well, you both have been a wealth of knowledge. And I know it was super helpful to everyone here. And I even learned some new things. I'm always learning new things, even though I've been in the community for so long. So this was This was really, really, really wonderful. Thank you so much. I have this recorded for everybody, so I will be sending this to everyone. And I can add Dr. Porter and Dr. Nyan's contact info if that's all right with you guys.
Yep.
Just your email would be, great. And yeah, thank you all so much for spending your night with us. And thank you so much, Dr. Porter and Dr. Nyans, for answering all our
Ellie,
questions.
thank you. Boy, you really carried the heavy load tonight. Thank you.
Yeah, thank you
It's a
so
team effort.
much.
Yeah, thank you so much for having us. We really
Thank you so much. All right. Well, thank you all. Have a great night. Bye.